Is it working?
It
Oh,
is. We got it faster than
hallelujah.
last time.
Oh, I was so worried.
I was a little worried too.
Oh my God, because technology is not my thing.
Yeah, and we're having some bad weather here, so I was like, great, this is just
Oh, really?
not going to go well. Yeah, it's
Isn't it
just,
supposed to be like nice, springtime, all that stuff?
yeah, and the cedar is blooming, and so are my allergies. So
Yeah.
it's a great
Well,
time to live in Texas.
well, great to see you.
It's great to see you. It's been a couple months. How are things going in Maryland?
Well, they're great. Things are blooming here too.
Yeah.
In Washington D.C., the cherry blossoms are blooming, and was it yesterday or Monday was opening day for baseball in Baltimore. So lots of stuff going on.
I mean, that's great. And is your new practice blooming as well?
Yeah, I'd like to think so. I'm an impatient person in general.
You don't
So
say.
So I've had to kind of, pace myself a little bit and realize that things won't happen as quickly as I maybe want them to happen. But I think in general, things are moving in a positive direction. People are already reaching out, emailing. In fact, I had a Zoom call with a patient with CDH1 this morning. So I think I think they're coming along.
And kind of just so you are taking patients. Let's just
Yeah.
clear,
Oh, okay.
baseline it. You're taking patients. What's the best way to schedule with you? Is the
Yeah.
CDH program research up and running? Are we waiting? When are you
Yeah.
doing scopes? All the things.
No, I think this is great because I know when I left the NIH, I know that I told folks, hey, is once we get up and going, we'll let you know. So there's, I think, two things. One is the actual study or the research that I was doing before that I want to continue to do here. That study is not open yet. As you can imagine, it takes time to write a study. You have to submit it through the various, mechanisms in the university to approve it and all that stuff. And that takes a little time. So I hope that it will be open soon, maybe in the summer. But on the other hand, I can see patients, and we've already been seeing patients with CDH1 and CTNNA1 for endoscopies, for endoscopic surveillance, candidates for total gastrectomy. The difference is that right now I'm not necessarily able to collect any of that information for research
Okay.
purposes in the way that I was doing it before, but if people still need to be seen or want to be seen, we can do that.
Mhm.
And the research will come. And then the last part is I was prepared. Um, so if people want to call, this is my office number, 410-328-2663. And basically, Michelle in my office will talk to folks and say, okay, how can we help? And then obviously people can email me too, which people have been emailing me already. So
So there you go. There's more research to come, but they can see
yeah,
you now if they want to. What, let's just talk about scheduling. Let's say they can't make it to Maryland. They find a doctor near them. If someone's just been diagnosed with CDH1, kind of what's next? When should they get their first scope? Kind of what's a good sequence or a
yeah,
pathway for people to follow?
yeah. So this is a common question. And so what I usually tell folks, as soon as you find out you have the CDH1 mutation, and my hope would be that you've spoken to a genetic counselor. So let's just assume for a second that maybe you didn't get tested through a genetic counselor, that you talked to your primary care doctor. I know people have been seen by their OBGYN maybe who ordered the genetic testing. So the first step is to talk to a genetic counselor. And if you've done that, that's great. But I know a lot of people haven't, okay? I'm making some notes here because I'm going to share this in a little bit.
Okay.
The second part is, so I've been thinking about this. The second part is that, if you're talking about your cancer
Mhm.
risk, right, the genetic counselor will go over your cancer risk, but really the first thing to do is what I would call screening. Let's see if anything is going on. So the first thing to do in terms of stomach cancer risk would be then to make an appointment to get an upper endoscopy, to get that EGD, okay? And if you're a woman and you're 30 years or older and you've not had a mammogram, then you should go get a mammogram. Now, we know that the recommendation is that women get mammogram and breast MRI when they have a CDH1 mutation, but you always start out with the mammogram first. If you go anywhere and ask for the breast MRI, they're usually going to say get the mammogram first. So it's not until you've had the endoscopy or the mammogram that you then maybe go and then see a surgeon, which a lot of people end up seeing a surgeon. So the surgeon should come, maybe after that. And the reason is a lot of people go see the surgeon first and they skip the other steps. And I think, really you want to do the other things first. So just as a recap, I like, there's a guy a long time ago named Tim Russer who, through one of the elections did a lot of this stuff. So
Uh-huh.
anyway, so genetic counselor,
Hmm.
right? Then your screening, cancer screening, and then, meet with a surgeon.
Hmm.
If that, but you really need to get the EGD and the mammogram, let's say, out of the way, because once in a blue moon we'll diagnose somebody with a cancer on one of those initial studies, whether it's the endoscopy or the mammogram.
And what's a realistic timeline for all of this?
Yeah.
Is it 6 months? Is it a year? What's your?
Yeah. I usually tell folks, again, once you know that you have the CDH1 mutation, it's not like you have to rush out and do it right away, but why put it off? Like putting it off months and months and months or a year, I think is maybe not the greatest thing to do. So I think once you get the diagnosis, you've talked to the genetic counselor, get a referral or make an appointment for the endoscopy. You're right, some endoscopy appointments might take 6 weeks or 8 weeks, depending on how far out they're scheduled. Mammograms also. But if you make the appointment, at least you know you're going to do it and you know you're going to get it done. I think putting it off longer than that, if you're that, 1% of people that might show up for that test and be diagnosed with cancer, the sooner you know about that, the better.
Yeah. And then it's making the decision, right? So after you have that first scope, now it's do you continue with surveillance or make the decision for surgery?
Yeah,
Um,
yeah, but even before you get to that point, right?
mhm.
And this is where I want to turn it back on you, and this is where I love having control, because you're such a great interviewer. I, I what I oftentimes learn from you guys is how do you through this at this point you've probably gone through the diagnosis and maybe the initial endoscopy or mammogram, and maybe you're trying to decide what to do.
Mhm.
But the bigger thing is, how do you tell the people around you, your family, your friends, and I mean, can you tell us a little bit about what that's like?
For me, so I found out about the gene in April of 2019, and I had my first scope with you August of 2019. And by the time that I came in for my scope, I had already decided I'm having the surgery. Um, and it's such a personal decision, right? It's so um, specific to your own circumstances. And for me, I didn't tell people beyond telling people at work and my very closest friends and, my parents and other people in my family who have CDH1. I didn't discuss it because first of all, I couldn't talk about it without crying. And there's nothing anyone can say to comfort you unless they're also walking the same path, which is why it's so important for seahorses to kind of help those who are at the starting line. The girl, Emily, who I found on Instagram when I was first diagnosed, she is the only person that like really brought me any comfort during those several months of deciding, because I was like, this is a girl who is like me. She's my age and she's 2 years ahead of me and she's doing great. Like I can do this. Like that was my comfort. Um, but there is a lot of feedback when you start telling people that you're going to have your stomach removed, because it's such a unknown surgery. The mastectomy, people get that. It's like, yeah, okay, like Angelina Jolie made that trendy. Like, we
Yeah.
got it. Like, we understand that prophylactically, that's a great decision. But to have your stomach removed, there's a lot of shock and awe. And it's very difficult to receive negative feedback when you're in such a delicate place of making that decision. And so I found that until I had the answers to the
Mhm.
most frequently asked questions, I couldn't talk about it with people outside of like my closest circle. Now, other people might care, but I'm very sensitive to comments. Oh, well, that's going to be a great weight loss system. Like, just on you, think about food more than any person else. Um, Most people are well-meaning, and nobody really knows what to say. And a lot of people are like, or you've reached your advice and you should talk to the doctor. Or let me ask my doctor. Or let me ask, it's like, oh, like, actually, the research, this is where I feel confident in deciding. But at the end of the day, like, you get one body. You have to be a good steward of that body. And for me, making the decision to remove the stomach was an easy one. Not making a decision was paralyzing. And I just couldn't move forward with life. But I will say, like, it's really easy to tell someone what to do with their body until you're the one that's receiving the diagnosis. And I'm like, you know what? You can decide what you would do when it's your turn.
So let me ask you a quick question. And by the way, I want to tell you that there was a lot of
Oh,
glitchiness
no.
in the last 2 minutes. So I know it's not your fault because it's the bad weather in Texas, but we just need to think about, we may have to go back and talk about that again. I caught most of what you said, but here's the thing. I want to know, like, what are the kinds of things, if you don't mind sharing, what are the kinds of things that people, though, were asking where you thought, what, either why are you asking me that, or maybe you didn't feel prepared to answer, or you felt that you couldn't answer even though you thought you knew the answer. Like,
I think a lot of people wanted to know, um, why don't you just wait? Why
mm,
don't you just wait it out? And then if it does turn into cancer, just do chemo. I got
mm,
that exact phrasing, just do chemo. Um, and people didn't understand why it couldn't be found in the
yeah,
biopsies. Why can't you just keep doing surveillance? And like, they didn't understand how sneaky
yeah.
um, the cells can get. And I think that still to this day is probably one of the hardest things to explain to people of why I chose to have the surgery.
Now, I got to imagine people asked you other things too, like, um, well, if you get your stomach out, how are you going to live, or something like that,
How
right?
are you going to live? Immediately, the first question, when I tell anyone, oh yeah, no, I don't have a stomach. Well, how do you eat? And I'm like, with my teeth. So it's, but that's a very common question. How are you put back together?
Yeah.
How a lot of people want to know if I have a colostomy bag. I'm like,
Oh,
that's
really?
different organ.
Well,
um,
yeah,
yes,
I guess it makes sense in the fact that, a lot of people, that it is a black box, and people don't really understand anatomy and whatnot. You're right. Wow.
yeah. But that's a very, they're like, people ask, well, does this mean that you can't have children?
Mm,
Um, does this mean, you know, basically, how do you function as a person day to day? I'm like,
yeah.
probably just as well or better than I did before because, I don't have the anxiety. But
So here's the other thing. Did I got to imagine people had strong opinions. Were people basically on either side saying, "Oh, you got to do this," or "Oh, you're crazy if you do that"? Like, did you get a lot
I
of
got
that?
a lot of you're crazy. I
Yeah.
didn't get a lot of outside of my immediate family, because my dad and I, did us both. We decided at the same time we
Yeah.
were both going to do it.
Yeah.
So we had a lot of support internally, but I
Yeah.
think externally, and my best friend who's a nurse, was very like, yes, you're doing this, like, and was a great sounding board. But pretty much anyone else, I was faced with almost immediate resistance. Again, well-meaning.
Yeah.
There's no ill intention, but they're they don't know all that I have just learned.
Yeah.
And it it just seems like I'm making a really drastic decision to like, oh, I'm gonna get my stomach removed,
Yeah.
And so
And
I
I sorry.
oh no, I was just gonna say, so I had a lot of people say like, you need to get another opinion. Here's my doctor's
Yeah.
name. You should talk to my doctor. And I'm like,
But I
I'm good.
I think you had made a comment to me either by email or something that somebody said, "Oh, well, you're so lucky because you'll lose weight," and like something
Yes,
like that.
that was a hard comment. Someone said to me, well, nothing tastes as good as skinny feels. And
Oh.
several people said, you'll never have to worry about your weight again. And someone was like, oh, well, that's a great long-term weight loss plan. And I'm like, I mean, go for it. If you want to do it too, that's fine. But, there's a lot of, I don't have any cheat days. But I've also heard that about mastectomy too, that it's an insurance paid augmentation. And,
Oh.
I'm like,
Yeah.
those are fighting words that
Yeah.
'cause that's you're willingly giving up parts of your body so that you can come back down to the same risk level as someone else,
Yeah.
and that's not fortunate,
Yeah.
or anything to be envious of. And also it's like there's to see how many people in our community who struggle with putting weight back on. It's like this is not a desirable outcome. Like, we celebrate when we are able to put weight back on because it means that our body is responding well, it's absorbing
Yeah.
nutrition. It doesn't, you become your priorities shift when it's not just about how you look, but is my body actually doing what my body is supposed to be doing?
Yeah, and I think for me, that's one of the things that I try to learn from you all and then communicate to other patients is there are differences, let's say, between prophylactic mastectomy and prophylactic gastrectomy. And while they both impact your life, they impact your life in very different ways. And some of them psychological and physical on both sides, but then at least on the stomach side, you know, you definitely can live without your breasts. We've had women that talk about going
Mhm.
flat, right? No reconstruction. There's no option there with your stomach, meaning there's got to be something there to take the place of what was removed, and what we have is not perfect. It doesn't, it's not like you put on a shirt and maybe nobody can tell,
Right,
right? It's like your body knows there's no stomach there. Your body knows that a major change has taken place.
right. I
Yeah.
will say that it is very interesting because psychologically, the I guess because you don't see your stomach every day, the gastrectomy was harder physically, and
Mm.
the mastectomy was harder mentally, because I was so visually aware of the change to my body versus my stomach. I'm like, well, yeah, I'm cramping, but I don't know. I didn't
Why?
see my stomach, every day. So it's very interesting when people ask, like, which was the harder surgery? I'm like, I don't know, because they were both. I mean, I wouldn't 0 out of 10 recommend either,
Yeah.
but
You're not giving this 5 stars or whatever on Google or
yeah,
whatever. Yeah.
I don't recommend it. But it is, both surgeries are extremely taxing in different ways. I've recovered so much faster from the mastectomy. Um, I mean, 6 weeks and, done.
Yeah.
Everything was healed, back to working out. But even with the stomach, like, I mean, I've been eating the same things for years now, and was in the fetal position 2 nights ago because something went wrong. Like, I don't know what it was, but I
Mm.
mean, so you're just constantly kind of reminded of the loss. Whereas the
Yeah.
mastectomy is just, once you get over the initial physical pain, it's just kind of more my vanity, which is not small.
Not gonna comment on that one. Um, okay. I'm gonna give the microphone back to you. You're a much better host than I am.
You did a great job. You did a great job.
Thank you.
Um,
Shout
so
outs to Stacy Martin, by the way.
Yes, love her. Um, let's talk about. So one of the things that people said to me were, just wait, just
Yeah.
have chemo.
Yeah.
So let's talk about survival rates, what it looks like surviving with hereditary diffuse gastric cancer, and maybe like where research and treatment is at.
Yeah. So I think one of the things that I try to start out with is that while there are, think of it as two kinds of diffuse gastric cancer, the hereditary kind that we're talking about today, and then the non-hereditary kind, which we call sporadic, which is by far the most common. There there are lots of people out there that will say, either because they've heard or they've been told, that somehow the hereditary form is worse or more aggressive. I think we don't really know. And my sense is that it's not necessarily more aggressive. The difference is, or the similarity is that if you looked at outcomes for patients with stomach cancer throughout the United States, so if you took 100 people who got diagnosed with stomach cancer in the United States, doesn't matter what stage they were diagnosed, 1, 2, 3, or 4, we know that at 5 years, only about 30% of those people, or 30 of those 100 people, will still be alive. That's pretty bad. And that tells you, just in general, that stomach cancer is a deadly cancer, and partly because our treatments are not as effective as we'd like them to be, and that most of those cancers are getting diagnosed in the United States, at least at advanced stages. Now, where it becomes a little bit hard to talk about the aggressiveness or whatever of hereditary stomach cancers, we see a lot of hereditary stomach cancers at the very early, at the beginning, right? Stage 1, take out your stomach. We say we found stage 1 cancer. And the vast majority of you guys, probably 100% of you, are essentially alive 5, 10, 15 years later. If you took 100 people with sporadic gastric cancer that was stage 1, even at 5 years, maybe around 10% of them would be dead of cancer. Now, you could argue, a lot of doctors or experts will argue, well, they weren't accurately staged, they were really stage 2 and they weren't stage 1. But my point of saying all of this is hereditary gastric cancer, regular gastric cancer, they're both bad actors, right? and we need better treatments for all of them. So if you had hereditary stomach cancer that was diagnosed at stage 3, let's say, your prognosis would be the same as somebody with sporadic gastric cancer at stage 3. So not better, not worse. And I hope that kind of answers the question a little bit, because this is a pretty common question.
Yeah, and it's devastating, and it's also, I think, for me, one of the motivators to go ahead and have
Yeah.
the surgery, um, because it is just so consuming once it decides to progress. And I wish that I could just have what you just said on a tape recorder and play it back to people when they ask why I had
I think it's
surgery.
called Instagram. I think
Yeah,
it's called Instagram Live. I think you'll have it on tape.
just play
But
this over
but your
and
but
over.
but your point's well taken, right? One of the reasons why there's this kind of reflexive, oh my gosh, your risk of developing stomach cancer is higher than the average person, you should take out your stomach. The reason why a lot of people don't think that it's such a drastic maneuver is because if you got stomach cancer, at
Mhm.
least, what we're talking about, advanced stomach cancer, our treatments are not that good. And it's, the other statistic that I tell people to keep in mind is breast cancer in the United States, we've got lots of good treatments for. It's still a horrible cancer. There's no good cancer, but our treatments are much better. So if you took those same 100 people, but instead of them getting stomach cancer, they got breast cancer. So they're all women, let's say 100 women with breast cancer, variety of stages, 1, 2, 3, 4, 5, not 5, 1, 2, 3, 4. I'll go back to medical school. The 5 year and at 5 years, near about 90% of those women will still be alive.
Wow.
90% versus the 30% for stomach cancer. So it's partly, it's not that breast cancer is a more benign cancer.
Mhm.
It's not as, it's just our treatments are way better. We have drugs that treat them for some reason way better than the drugs that we have to treat stomach cancer.
And does that go back to just funding and research, or?
I think it's I think it's a little bit of both. I
Okay.
think number one, breast cancer is very common,
Mhm.
right? There's a lot of it around, and so when there's more of it, there's more of it to study. It's easier to study. Remember, stomach cancer in the United States is not very common, so there's maybe only around 30,000 cases a year, even though around the world it's one of the more common cancers. So I think that does hurt a little bit when it's not a common cancer. And then, of course, the funding for breast cancer research is just phenomenal. A lot of money going to breast cancer research, and unfortunately, not a ton going to stomach cancer research.
So it's interesting because stomach cancer is not as common or kind of as talked about in the US. I think something that patients who have opted for surgery kind of run into is when we are interacting with our other medical professionals in our life, communicating. They probably won't ask, why did you do that? But there
Yeah,
is a lot of, you did what?
yeah.
And what are some good ways that patients can communicate with their doctor? I've been fortunate, like my gynecologist, when I told her I was having the surgery, we did a consult and she was like, tell me everything about what you're going through, and she's just sat there and took notes. She's an amazing
Mm.
doctor, and but you don't, that's, she's the anomaly. That's not
Yeah,
kind of not common.
yeah. So I think I've heard this from a lot of you guys over the years that, it's one of those things where you go to the doctor and you feel like you're the one educating them. And I know that's got to be like a horrible feeling. Although I've heard over the years that it's not super uncommon when people have like a rare problem.
Yeah.
I hear from, parents of kids who have rare genetic syndromes where, they've learned a lot and they know a lot and they do a lot of educating through advocacy as well. This I'm a picture person, so that's why I draw people pictures. But like you have your stomach, right? I always tell people there's the stomach, esophagus comes down, stomach, the pylorus is the little valve, and it goes that way. So one of the things I've heard is that people go into the emergency room. This happened after a car accident, banged up their car really bad, go into the ER, and all of a sudden they're like, have you ever had any surgery, whatever? Oh yeah, I had my stomach out. They're like, nah, you still got some of your stuff. No, I had my stomach. Nah, you probably had one of those like gastric bypass things. No, my stomach's gone. No, there's no, and they're like, hey, my leg could be broken because I was in a car accident. You mind looking at my leg and not focusing on the fact that I just told you I had my stomach out? So I think this is where, I don't know the best way to do it. People have asked me about like medical alert bracelets and things like that, but it's like if you had a medical alert bracelet that says I don't have a stomach, I don't know, maybe people thought that you got it at a party or something, and it's like a gag gift or something.
Hmm.
So I don't know, but what I usually tell people is that if I showed a doctor a picture and I said, okay, that's what that looked like before, and this is what it looks like now, maybe they would get it, right? So I draw this picture, where I say, okay, the stomach's gone, remember? And now that part of the intestine, the duodenum, is still there, but we brought up another piece of the intestine and sewed it to your esophagus way up here. This part right here is called the roux limb, R-O-U-X, okay? And then we sew it back together down here, so all the juice that comes from the bile and the bile ducts and the pancreas travel down this mix with your food right here and then gets absorbed. And I think if you showed this or somebody showed this to their doctor, the doctor would go, the stomach's all gone. It's not like a bypass, or it's not like you know. But then the problem is, right, is it's not just an anatomy question, right? It's all the other stuff, right, that you guys have to deal with.
Yeah, it's I I had a little trip to the ER recently, and I blew that doctor's mind. I mean, it was just, he couldn't even focus on anything else because, and they like kind of left, and then they came back and they were like, what was that thing? That CD, I was like, CDH1. Yeah. And my
They're in the back
personality,
room. They're in the back room on Google going, what the
Googling,
heck?
yeah.
Yeah.
What? But it's very, and when I had mastectomy, you had put together like a patient emergency letter,
Oh.
and I had copies of that letter in a folder, and I just handed one out to my nurses, the anesthesiologist, to the doctor. I was like, here you go, please read this. Um, but now I do wear a medical alert bracelet. I don't have it on right now, but because I have so many allergies,
Yeah, but it doesn't
I've got
say you don't have a stomach,
it.
does it?
It does. It says
Oh,
total
it does.
gastrectomy. It says total gastrectomy, and then all it says no blind NG tubes,
Okay.
and it says no sugar.
Yeah.
Um,
Okay, so it says
and
more, but it says more than just I don't have a
I don't
stomach.
have a stomach.
Okay,
Yeah,
okay.
yeah. And then it goes into my long list of allergies. Basically don't give me anything but air. So it's
No
otherwise
cats, no cats, no nothing.
I'm a goner, Don't give me any medication. Maybe some mint tea or something. But it's uh I think one thing that patients have to realize is being an advocate for yourself is not being bossy.
Yeah,
It's
yeah,
not being
yeah.
an inconvenience because your doctor wants to help you. They just don't know maybe how to, or just need a little bit more understanding. Because I did have a friend who was taking their medical board, and they were like, "You helped me on one of the questions because." it was which genetic variants
Yeah.
causes gastric cancer.
Yeah. Yeah.
And she was like, I got it right. And I was like, you're welcome.
But by the way, real quick, I've said this to a few people before. I said if you're talking to any physician or a provider that where you're trying to educate them and they seem annoyed or offended or whatever because they know better than you do and you're the one with the CDH1 thing, that's where I say it's okay to find another doctor.
Yeah.
Because I think you have to have a willingness to say, oh, I don't know everything, right? Because I don't know many people who know everything. In fact, I'm pretty sure nobody knows everything. So, I think if you're in that position where you're advocating for yourself, but you're getting pushback, it may be a sign that, you don't need the smartest doctor in the world, right? You just need one that is willing to work really hard on your behalf.
Yeah. That's great advice. And that it's okay to say, this isn't going to work for me. I'm going to
Yeah.
go find something else. So,
Listen, yeah, I mean, I hate to say it, but it's like if you went to a dentist and you didn't like the dentist, right?
yeah,
You'd maybe find another dentist. So anyway,
right. I'm very, very fond of my dentist,
me,
but
me too, me too.
um, okay, let's do a little rapid fire.
Okay, I'm ready.
I've collected a couple questions. Okay, common question. Should I gain weight before gastrectomy?
No, my light just went off in my room. No, you shouldn't gain weight before your gastrectomy, and here's why. Well, first of all, I know why people think that, right? Because they say, okay, I weigh this, everybody's telling me I'm going to lose weight.
Hmm.
So if I gain weight and then I lose weight, I'll end up exactly where I am now.
Right.
And unfortunately, that's not the way it works. So what I tell folks is gaining weight generally is going to be associated with other health problems, right? There are lots of things associated with gaining weight, whether it's high blood pressure, the potential for diabetes, fatty liver, which is a huge cause of liver disease now in this country. So you're going to lose weight no matter what, and it's almost as if your body's going to have its own set point,
Hmm.
like a thermostat, and you're not gonna fake out your body, right? It's not like you're gonna be like, "Oops, psych, gotcha." It's not gonna happen that way. So don't gain weight. It's just I know people think about it, but just no. And that
Uh,
wasn't rapid fire. That was too long
I
of an answer for
know. Well,
rapid fire.
it's
I'm
faster
so
questions.
sorry.
We should call it random questions
Okay,
instead of
we'll
rapid
do
fire questions.
random. We can do random and we can do rapid.
Did I ever tell you that between, because I was supposed to have my surgery April of 2020, and then obviously it got pushed back because of
Yeah,
COVID. So I
yeah,
had from April to August where like I knew I was going to have surgery, but I was
yeah,
in quarantine. I ate everything. I would get like entire key lime pies. I wasn't trying to gain weight. I was just like, what
yeah,
are
yeah.
all of the foods that like I might not be able to have? I mean, the image of me standing in like the shadow of my refrigerator light, just like eating a key lime pie, putting it back in the fridge, and it's still one of my favorite memories.
I would
And
love to have a picture of that, by the way. I would love a picture of that.
just like a feral raccoon just going nuts every night. It was
But
just
but by the way, but see what you were doing, I think is what any normal person would do, which is like, it's kind of like I'm never gonna, or not never, but I'm not gonna eat potentially like this again.
right.
So let me go out there and eat all the stuff that I love. Now,
Oh, it was
tell
great.
people, you have to be honest though, are there things now that you eat that you never thought you'd be able to eat?
Yes, it has taken a while, but I can finally eat ice cream again. That took me about 3.5 years to work myself up to. But
Okay.
I can have like a fourth of a cup, which is pretty
Yeah.
significant.
Yeah.
The one thing that I can't eat, and it was my last meal. So my last meal, my friend who lives in DC, she's an amazing cook. She was like, I'll fix you anything you want. What do you want? I was like, I want a steak and a baked potato and like s'mores.
Yeah.
And so that's what we had. I still can't eat steak. My dad can, but for whatever reason, I just can't. It just it's not worth it.
Yeah.
But so I can't do steak, but I can do the baked potato and the
Okay.
s'mores. So, honestly, winning.
Yeah. Well, if you're ever on death row, there you go. There's your last
Yeah.
meal.
Hopefully,
When you're on
hopefully that's not.
death row for killing that key lime pie.
Yes. Now, guilty. So, okay. Are there trends and habits of people who tend to do better after surgery?
Oh, this is a tough one. Okay, there is none, and I'm going to tell you why. I used to think there was,
Okay.
and I used to be a believer that younger was better and older not so much. And my mind has been blown by people that I thought were going to fly because they were young and they were healthy and they struggled with, whatever it was, nausea, reflux, this, that, and the other. Okay. And then I remember one guy in particular, and I can't give too much away because people might know who he is, but he came in, he was nervous, as a lot of people are. He was 65-ish, okay, retired, living his life, but nervous as all get out. How is this going to mess with my life? And I was like, oh God, this guy's gonna struggle. Like, what am I doing? Like, should I even take his stomach out, right? Like, I'm gonna ruin his life. Do you know this guy to this day has like no problems? He like eats anything he wants. He's out there golfing every day. So what I tell people is that I wish I had some way of predicting it. And we've tried before to look at, is it men versus women, old versus young? We're not finding much. It's just everybody's body is just so different.
I mean, and then even from day to day,
Yeah,
you can have a good
yeah,
day or good 6 months, and then you have a bad day. So
yeah, yeah,
our bodies they're
yeah.
fickle.
There you go.
Um, okay. Big topic amongst seahorses is bile. What
Ah,
causes it?
yeah.
Why do some people have more of it? Is there a surgical fix to it?
Mm, well, this is a tough one. So,
And all the hard hitting questions.
yeah, so I'll tell you a little bit of anatomy and whatnot. So, your liver makes bile, and your bile is something that your body needs to digest food. Okay? Back to our anatomy lesson. The liver is here. The
Hmm.
bile ducts are these little tubes that carry bile out of the liver and dump it into this part of the intestine.
Hmm.
You guys still have all of that machinery, but instead of the bile mixing with the food right after it comes out of the stomach, it's got to travel all this way down here
Hmm.
where the food's coming down to mix down here. Okay, so that's one of the reasons why you guys are still able to digest food, because you have all the mechanisms to do it, the bile and the pancreas juice and all that stuff. But this thing, this length right here is called the roux limb. That length for people that I do the operation on is about 50 centimeters. The bile comes out down here. Well, it's supposed to go south. It's
Hmm.
supposed to go that way. And for some reason, in you guys, in some of you more than others, that bile takes a turn north and it likes to go back up into your esophagus.
Gonna
Now,
party.
there's a couple reasons for that, because all of the natural kind of valves and things that were in place with the stomach aren't there anymore. And so there's no anti-reflux mechanism. So all this stuff can just bubble up. And I don't really understand it. Again, it goes back to like why some people, have fewer problems after gastrectomy and some have a lot of issues after gastrectomy. I think there are just some anatomic and physiologic differences in people where some people's bile reflux is just horrific,
Hmm.
and then some people are like, nah, I hardly ever get any bile. And that's also why we ask you guys to be careful in terms of gravity, right? Because without any anti-reflux mechanism laying down after you eat, could not be a party.
Like a seesaw, you know?
Yeah, yeah. So. I wish I knew the answer. It's something that I'm interested in, obviously, because I feel bad when you guys are like, oh man, this bile is killing me.
Do you ever see a correlation between people who had acid reflux before surgery having
Mm.
a harder time with bile reflux?
Great question. However, I've not seen
Mm-hmm.
that relationship, and I suspect that it's just because they're different mechanisms. One is acid that's secreted from the stomach when you have your
Mm-hmm.
stomach, and then this bile is just, just I don't know.
Yeah. All right, my last rapid fire, since they've been
This
so
has not been very rapid at all. But anyway,
I would say rapid for us,
mm,
too long-winded.
true,
Um,
true.
Advil, I know that we can take Tylenol, but
Yeah.
why can't we have Advil after surgery?
Yeah, so I think that the main takeaway is just like if when you had a stomach,
Mhm.
if you took a lot of aspirin or ibuprofen, you could irritate your stomach, right?
Mhm.
Those drugs do some certain things that just can really irritate, the lining of your intestines. But your stomach has a lot more of a protective mechanism. It's
Mhm.
thicker, it's got mucus, all this stuff that your intestine doesn't have.
Mhm.
So, just like taking too much Advil or ibuprofen on for your stomach could be damaging. The difference for your intestine is because the intestine is less able to protect itself. There's a risk really of perforation because it does so much damage to the intestine that it's essentially like, creates a hole in the intestine. Now, I tell people if you have like your knee hurts after going for a jog or your back hurts after a long day sitting in the office, taking some ibuprofen is not going to hurt you.
Mhm.
It's really that sustained use of aspirin daily or multiple times a day for several days at a time, right? That's what you need. That's what you need to avoid. But you don't have to like never take it again. You just can't be taking it all of the time, you know.
Makes sense. Which hopefully, you know, hopefully we're all just healthy little seahorses and have no aches and pains. That's what I wish for every seahorse.
I
No
know.
aches and
Hey,
pains.
you know what I want? I would love like a little fish tank with seahorses in it. Wouldn't that be so cool?
I think we could probably make that happen.
Well, but I mean, like I'm not saying I want somebody to give it to me, but I mean, just like, and I don't want to kill them either. And I don't know if I'm really good with animals, but, I want to, well, wouldn't it be horrible if I got seahorses and then they died? That would be, I'd never live that one down.
You could not tell people that. You
Oh,
could
yeah.
not.
I could see it now. Jeremy Davis, seahorse killer, you know, it would be horrible.
Maybe test it
Horrible.
out without telling any of us, and then once they've
Okay.
survived like a year,
Then
then
I
be
can
like,
tell you,
look at
look at
my
me.
herd of
Look at
seahorses,
my herd of seahorses.
Uh,
Yeah. Hey, real
uh,
quick, somebody put in the chat real quick, no stomach for cancer. I don't know who's running that unless it's a plant. It said something about intestinal motility and bioreflex. And yeah, I think there's a component of some people's intestines don't function like
mhm.
everybody else's. We know people that tend to be constipated, tend to have more diarrhea. Everybody's intestines function slightly differently. So I think there's a component of intestinal motility that contributes to why some people do or do not get bile reflux. So anyway.
And maybe next time we can talk about constipation and kind of,
Ooh, yeah.
you know,
Well, constipation's a big deal for you
it is.
guys.
It is.
I think so.
Usually you're on one end of the spectrum or the other. I mean, so
I think a lot of things in life, you're on one end of the spectrum or the other. Oh,
we
God, help
shouldn't
us
be
all.
having this much fun talking about such serious matters, but
Well, you know what though? The way I look at it is I always tell people, I'm serious about my work. I'm really serious about, or I take what I do very seriously, but you can't take yourself too seriously, you know?
no,
Yeah.
no. I mean, it's so much more fun to,
Yeah.
if you're not laughing, you'll be crying.
There you
So
go. There you go. Hey, listen, we should do this again.
Let's do it again sometime. This was
Okay.
great. I will post this. I apologize to everyone for the poor video quality, but at least the audio will definitely be there. But maybe next time it'll be sunny weather here in Dallas.
I
So,
hope so.
yes.
Good to
All
see you.
right. Okay. Take care.
Bye.
Bye.